it's open for discussion. I have one question in my mind. That in acute emergency, in a casualty, when the patient comes with ACS, and we are all under pressure to take a decision whether to do standard coronary angio and go for a primary angioplasty, or any other test to be done to decide whether the patient needs a coronary angioplasty. What should be the test?
Yeah, very good question. I'll answer this. Very simple. This is called acute chest pain syndrome, role of nuclear imaging. So acute chest pain is, where the ECG is equivocal, there is no classical ST elevation, nothing. What I think that is your point, Dr. Bandukala. If we'll do the resting SPECT system by perfusion scan, which Dr. Prabhu had presented, he had gone for another meeting. So if it will show a ischemia or a infarct, then we can detect, we can go ahead with the, if it is positive, showing a perfusion defect, you can go ahead with the angiography or angioplasty. If it is showing a normal, then you can save angiography. After all the symptoms will go away, discharge the patient, Dr. Bandukala, after 3 to 4 or 6 weeks, call the patient for a regular stress and rest SPECT system by myocardial perfusion scan. I think
and if troponin is high, but ECG changes are wishy-washy?
Yeah, troponin may be high, but if you do a resting perfusion scan, one shot, you can detect whether the person has got MI or acute coronary syndrome or ischemia. Then go ahead. If it is there, even if troponin is high. Thank you.
Thank you very much.
You may go for a coronary angiogram, sir. If the patient is having mild to moderate risk factors, see if the risk factors are not very clear, the pain is atypical, your symptoms are, you said your ECG is equivocal, the person may be sent for a coronary CT angiography.
Yes, coronary CT angiography, yes.
So that would not only show the lesion, it will also show you whether it is doable or not. So it may be ischemia. Whether it is doable or not, that also will be.
Yes, you can do a coronary.
And sometimes the patients may have, there is a symptom overlap with pulmonary thromboembolism and aortic dissection. So everything will be sorted out in one go. So these are different algorithms which can be adopted. One is nuclear medicine, another is do imaging. And if you obviously have a clear-cut doubt, you go for a catheter. If you think it is ischemic heart disease, the patient goes for a catheter.
Any other question, Dr. Priya, in the chat box, please?
Sir, I thought since Elizabeth could not, present her, let's give her 2 minutes. Elizabeth, if you could just summarize how MRI can help patients specifically in evaluation of diabetic cardiomyopathy. You don't have to exactly show your slides. Just if you could just briefly talk about, where in patients with diabetic cardiomyopathy, MRI, cardiac MRI, what all can be, what is over and above what are available with CT or with nuclear.
Dr. Elizabeth, please. Dr. Elizabeth. Where is Please mute your.
Yeah. So the role of cardiac MRI is actually detecting undetected coronary artery disease. So a diabetic patient may be actually having coronary artery disease, which has not been detected by the standard evaluation that the patient goes through. So a cardiac MR technique is very powerful to pick up ischemia as well as infarction. So the images I was trying to show when I had internet connectivity were patients who were diabetic patients. The stress patient was a pre-diabetic patient who suddenly came with angina, and thus adenosine stress cardiac MRI images showed a ischemic lesion in the LAD territory. So in this patient, the ischemia was detected early and the patient went on to have a cath angio and angioplasty and stenting. The other situation is the patient has gone beyond ischemia and has had a frank infarction. So infarction is very well picked up on cardiac MRI technique, the delayed enhancement technique. So these are kind of the bread and butter of cardiac MRI that we do. Now we have more sophisticated techniques like the parametric mapping and the ECV that I was talking about. So ECV, actually the values are higher in patients, the diabetic and the pre-diabetic patients as compared to control. So we can actually detect patients who will benefit from follow-up by using these early techniques. Similarly, spectroscopy is also a very sophisticated technique which will pick up diabetic patients before they present with chest pain and come to the emergency situation. So cardiac MRI is having an increasing role in diabetes and perhaps is underutilized in our country.
Dr.
This is to Dr. John Christopher. Hello,
Johan,
sir. Good afternoon. Yeah,
Yeah.
Dr. Christopher.
I can hear you, sir.
Yeah. This is in relation to the CT calcium score and the prognostic marker. Is there any Indian data collected or studied with CT versus conventional angio to show the prognostic valuation?
No, sir, we don't have Indian data. We as the group, Indian Association of Cardiac Imaging, and Dr. Elizabeth has been the founder president, and Priya also is a member. We have started a nationwide calcium scoring from all our institutions. It is just underway. It is ongoing. There are some challenges, as you know, when you do anything as a collectively as a nation, but it is ongoing. And once we have the data, we'll definitely obviously publish and share it. But right now we don't have Indian data, pure Indian data. There is some local data from Chennai, Dr. Mohan's group, and some group from Dr. Rajiv Gupta, but we don't have large data to really talk about it. But now calcium score has entered the realm of preventive cardiology for the first time. So I think physicians, cardiologists are looking at it very closely. And there has been problems about radiation, but the new scanners are extremely good, and you get sub-millisievert radiation doses. So I think it is going to pick up very soon. Thank you.
Oh yeah, that reminds me of something which I was going to talk about after Dr. Jadav's presentation. We recently completed a study wherein we did calcium scoring of 100 patients and calcium scoring using simple flash non-gated sequence. So the pickup, the calcium score which was we measured manually versus the one which is measured usually with the calcium score, the usual calcium score, there was no significant difference between the two. So it's a good thing which Dr. Jadhav was saying. Any NCCT done for any case scenario, do have a look at the calcium score. See, we all know the importance of zero calcium score. An absence of calcium score will reassure you that this is a patient who is unlikely to have a very, very less likelihood of having a coronary artery disease. So just don't look for a calcium score study itself. So any NCCT can give you equally good information. So that is something which I wanted to add after Dr. Jadhav presented his.
Can I add something?
Yes, please. Dr. Pradhan, go ahead.
We had worked out, I think 3-4 years back, 30 patients of cardiomyopathy, taking into consideration both the MPS as well as CTCA. And we evaluated both group of patients, and we showed that both are giving similar kind of information in terms of prognosis from the calcium scoring and an MPS. This result is still awaited. It is under publication. And I think this is the kind of study, but it is not specifically with the diabetes.
1 minute left, sir.
Okay. This is for your information.
Yes, sir. Calcium score, no doubt, is a very, very powerful tool, specifically if we are talking about a zero calcium score. And in diabetic patients, where most of them are asymptomatic till very late. So this is a very good prognostic tool and can be used to monitor your patients.
Okay. Any other questions? Nothing?
Yeah, just one comment.
Okay, please.
Yeah. So as we are talking on diabetes, and I made that point in my talk. So calcium is part of the wall remodeling and whatever is going on, the microvascular thing. So right in the morning, all the eminent speakers spoke and emphasized on the microvascular disease. So when you are doing, so even calcium, though it's very easy to measure and it is doing a very good job as of now, lot of things, but there are downstream, the whole microvasculature is deranged. So there may be a calcification or epicardial disease, which is a diagnostic scan, and there is a generalized microvascular disease as such in a uncontrolled diabetic or on inadequate medication diabetic. So if you are going to incorporate that microvascular disease in your algorithm to treat or modify the lifestyle or whatever, so you need to have that information upfront in the form of a generic information on the inherent nature of the microvasculature as a whole, not epicardial. Yes, when you are looking for diagnosis, the patient is showing some symptom of ischemia and you want to rule out, and then you say FFR comes up against other diagnosis. But how about the microvasculature? So that theme of various technique in diabetes mellitus is more relevant to the microvascular disease. That's my say. And those techniques which are giving you the non-anatomical asymptomatic patient microvascular changes, those techniques which bring out that aspect, those are important. And there's
just to answer Dr. Gambhir, the thing is that yes, every modality has got their own limitation. You have very correctly pointed out the microvasculature is very common in diabetes mellitus. So this is the advantage of estimation of CFR over FFR over catheter-based FFR. So microvascular dysfunction can be very well detected by CFR as compared to FFR or as compared to catheter-based FFR. I want Dr. Priya to have the input on this. Yes.
So I was saying, true sir, coronary CT angiography is only good for epicardial vessel involvement. So if a diabetic patient is there and I am suspecting in ischemic changes, I would do a MR. See, MR is the investigation which will pick up the microvascular obstruction, which is the most important feature, and it is the gold standard investigation for evaluation of myocardial microvascular obstruction.
But not dysfunction.
Perfusion studies. I am not saying, I am not advocating any particular perfusion study. It could be any perfusion study, any imaging modality. So perfusion studies, microvascular obstruction, evaluation, fatty infiltration, early diastolic dysfunction, all the features which are typical of diabetic cardiomyopathy are best picked up together in a cardiac MR study. So you can talk about your study. Yes. So I'm just telling, if of the two, CT will just give you epicardial vessel involvement. So it is not the investigation of choice. So calcium score we are talking because it is something which we do in asymptomatic patients, and we suspect that these patients will be asymptomatic. The diabetic patients will be asymptomatic. So it is something which is minimal radiation, can be easily done. So can be incorporated as part of an executive health checkup. So calcium score has one area, and second is if you are suspecting the patient has diabetes and you are suspecting cardiomyopathy, cardiac MR is the way to.
Okay, thank you. We are overshooting the time. Okay, thank you very much all the chairpersons like Dr. Priya, Dr. Bandhukwala, Dr. P.K. Pradhan, and we had very good discussions in imaging.